Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Inside the Issue. As today we talk about the management of metastatic urothelial bladder cancer. We have a great faculty today, Dr. Terence Friedlander from the Helen Diller Family Comprehensive Cancer Center at the University of California, San Francisco, and Dr. Petros Grivas from the University of Washington Fred Hutchinson Cancer Center in Seattle. We also have some other investigators who are participating in this program who completed a survey that we're going to show you during this webinar, and we thank them very much for their participation. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room, and we'll talk about as many of these as we have time. As always, we have a 1-minute quick pre and post a survey for you to take. If you do that, we'll learn a little bit more about you, and you'll get a lot more out of this conference. We do webinars all the time. Next week, we're doing one specifically for oncology nurses, a follow-up to the Oncology Nursing Society, a meeting that we went to a few weeks ago. We'll be talking about chronic lymphocytic leukemia. Then we have a great program on July 11th, looking at high-risk MDS. A lot of really new, interesting, challenging things, new developments going on there. And then on July 13th, a really interesting program on dermatologic cancers, including melanoma. And I'm going to tell you a little story about one of the studies we're going to talk about there before we get started here. We're doing another program on myeloma and bispecific antibodies on July the 18th. And then ASCO was super hot in terms of ER-positive breast cancer. So we're going to dive into that on July the 20th. We're going to also continue our soft tissue sarcoma series, and we'll be doing a program on July 25th there. We know a lot of people end up listening to our webinars when they're cars and driving. If you're into audio podcasts, check out our Oncology Today series, including a recent program with Dr. Tagawa on metastatic bladder cancer that we're going to be talking about tonight. So I met with both faculty members in the last couple of weeks to record an in-depth presentation for both of them. These are the title slide. Dr. Friedlander reviewed immunotherapy-based strategies in the metastatic setting. Dr. Grivas talked about second-line therapy and novel new developments, including anti-HER therapy, which I think you're going to find really interesting. Those links to those presentations are in the chat room, and we'll also be sending that out by email along with the replay of this program. But what we're going to do here tonight is sort of try to take it to the next level and introduce the findings of a survey we did of our faculty of their usual treatment practices. Here are the papers that are reviewed in these programs. And again, if you want to get all the details of the papers, just check out. Also, both of the faculty presented cases from their practices during these recordings. And these are really great sessions that I know you're going to get a lot out of. So we're going to start today with a couple introductory comments, and then we're going to dive in, talk about first-line therapy, second-line and beyond, and then new strategies. So, Terry, I was mentioning that we have this melanoma conference coming up, and I was looking through the slides from Dr. Lipson from Hopkins, and I see this study looking at adjuvant pembro in melanoma, plus or minus, and it had a bunch of numbers there. And I see it's all randomized phase 2. So, we need a phase 3, but has a rate of 0.56 for progression. So I'm like, well, what did they add to the pembro? And that's what was super interesting, because I don't know if you remember a company by the name of Moderna. Well, here they are. This is an RNA vaccine. I do not understand how they do it or what they do, but the bottom line is they target 34 neoantigens. It's individualized to the patient. And it's, quote, an RNA vaccine, although it seems very different than a lot of vaccines we've heard about. I just wanted to let the audience know about it. I don't know if I'm the last one to hear about this study. Everybody knows about it or not, but I was just stunned when I saw this thing. And maybe people smarter than I am can understand how it works. So I don't want to spend a lot of time. I just want to alert you all to it. We'll talk about it in the webinar. But Terry, any thoughts about this? Of course, immunotherapy has become so critical. You reviewed that in your talk. Any thoughts about, we're constantly trying to add stuff to PD-1 inhibitors. Any thoughts about this kind of strategy?
Yeah, I think this is a pretty interesting strategy. Most of the immunotherapy that's already approved is not a personalized immunotherapy. It might be a checkpoint inhibitor, and we're trying to understand who's going to respond and who isn't. And this type of strategy is actually a little more interesting because they take tumors, they sequence them, they try and identify what's mutated or what's different about the cancer, and then mimic that structure, create that structure as an mRNA, and then give it back to the patient in a way to stimulate the immune system to essentially go hunt for those antigens. We've seen some success with that strategy. I think this is probably one of the more successful strategies. There's data out there that suggests that using mRNA as the vehicle for the vaccine is better than just using a protein, for example, or like a dead piece of cancer. So obviously, we need to learn more about this. And as you say, we need to see it in bigger cohorts. But this is a couple hundred patients in this one study in melanoma. So if it's successful there, maybe it's successful in bladder cancer, maybe it's successful across solid tumors. But it obviously needs to be evaluated.
Yeah, I mean, the melanoma people have always led the way in terms of immunotherapy. Petros, any thoughts? I guess Moderna originally was targeting cancer. Then COVID came along. They took their technology and applied it there. But I was just excited because, if they could figure out COVID, I'm a little bit more optimistic about this possibility. Any thoughts?
Neil, I agree with you. It's very exciting and very interesting. I agree that Moderna as a company was working on cancer vaccines using mRNA technology to try to get in the front of immunotherapy and stimulate the immune system against, as Terry mentioned, cancer-specific neoantigens using this personalized approach. And when the COVID-19 pandemic happened, the emergency phase, they pivoted, they switched to developing the COVID vaccine. So the work they had done on the cancer vaccine actually paved the way to develop the Moderna COVID-19 vaccine. I think the technology is very promising. The early data that we saw from the pancreatic cancer definitely captured the attention. Is a good signal. It's a good promising study. Definitely requires further investigation. It's not ready for prime time, but I share your enthusiasm that other companies too that actually take this approach. So we may see actually more than one of those vaccines being developed. And I think the adjuvant setting is an interesting one because of the concept that immunotherapy, especially the vaccine immunotherapy, might in theory potentially work better in the MRD, minimal residual disease scenario. So I think more to come and more trials are being designed in that context.
So I wanted to ask you about another thing, and I saw another email from ASCO this morning with, when we were at ASCO, we did, I think, 10 programs at ASCO, and at every single one of them, docs were asking about chemotherapy shortage. So I saw this morning, and it's been circulating around, really some great advice in there in general. But what I wanted to ask you about is what they specifically say about bladder cancer. And also as a way to start to get into, one of the main questions I have for you, which is what is the current and future role of EV Pembro? But in any event, first, here again, I just picked, if you look at the ASCO thing, they go through adjuvant, neoadjuvant, et cetera. I just picked out first-line therapy because we're talking about it. And also, because I was very curious, you don't really have a non-chemotherapy option in a lot of the other cancers. They're like, last night we were talking about endometrial cancer, you need carbo. You need carbo for ovary and lung, et cetera. But you guys have one other thing that, of course, is very interesting. And Terry reviewed this in his talk, and we'll talk a little bit about that, which is a non-chemotherapy option of EV Pembro. So before I get into that, Terry, what is the situation at your place in terms of chemo shortage? Is it just carbo? Is it more cis? And what are you doing?
Yeah, so here at UCSF, we have shortages, unfortunately, of both. And it's a major problem, not just in bladder cancer, but just across oncology, because platinum, I think of as the sort of the mainstay of how we treat people with chemo. It varies. Like initially, we had a cisplatin shortage, and then actually there was enough cisplatin, but then we had a carboplatin shortage, and now they're both in somewhat short supply. So we have committee that adjudicates who should be getting this if we run into really short supplies. But it's a big problem. And as you said, fortunately in bladder cancer, we have this new regimen, this enfortumab vedotin and pembrolizumab, which doesn't involve any platinum and looks pretty good. And we'll talk about that more in a little bit. So that's potentially helpful, for some of our patients, but it's really unfortunate. It's really dire in many respects, because, patients who need this for example, germ cell tumor patients, there's no substitute for platinum, and actually for cisplatin, they really need that. So we need to fix this problem. I know there's a lot of attention being paid to it at the levels of government, et cetera, but it's really a challenge.
Any comments? What's going on at the Hutch there in terms of chemo? And what about all the people? Are the people sending you patients who they can't give chemo to, for example?
Neil, great question. Thank you for raising this issue. It's a national emergency and crisis for sure, as Terry and you mentioned. And we appreciate the ASCO guidelines as a guide to help us, and community practice, academic practice to deal with this issue. And of course, the advocacy they do, in the policy level, how we can deal with the manufacturing challenges and the business problems. We have drug shortages across the country. Here at the Hutch, so far, we're doing okay in terms of having adequate amounts of those drugs. However, we're trying to be as proactive as possible because we don't get enough vials down the road, we may get an acute crisis. So proactively, we have an algorithm how we would prioritize if the problem really comes in our front phase. Patients with curative intent setting, of course, versus palliative intent, we may prioritize the former. We talk about patients where they started treatment versus those who may start in the future, about different disease types who may need it more and they may have less alternatives, talk about clinical trials and how we deal with those situations as well. And as you mentioned, there is a significant amount of patients who may be referred to us from the community centers because they do not have access to carboplatin. This creates a significant challenge because obviously we want to help every single patient in an equitable manner across the board, but it gets very challenging, as you can imagine, when we have a certain amount of cisplatin and carboplatin, how we prioritize those patients. So it's a case-by-case scenario and discussion with the community oncologist to help as many patients as we can.
So, yeah, very difficult, and it must be very, very difficult to discuss this with patients, particularly when you're kind of almost in a rationing situation. There's a big article in the New York Times about this. I think it was in the last couple of days as well. But it also made me think a little bit about another question. I'm just going to pop out there to you when I sort of saw this thing and I looked at it. Terry, because I've kind of been thinking, and we're going to get into the data and all, and we're going to show the survey, but I just want to pick your brain about one other thing that sort of crossed my mind, which is I've been sort of focused on EV Pembro in terms of older patients, platinum ineligible, but like, what about for this, younger, no comorbidities, cisplatin eligible? Terry, I know there's a phase 3 trial comparing chemo avelumab maintenance to EV Pembro. What that study is going to show, it's maybe a little bit tricky, but theoretically, do you think right now EV Pembro is a reasonable alternative if you could present it to a healthy patient who's cis eligible?
Yeah, I think it's a great question. The data that's been generated with EV Pembro has all, like 100% of it has been in the cisplatin ineligible population. So we know that EV Pembro seems to work pretty well in that group. Response rates are almost 70%. Long-term outcomes are good. People are living, 2 or 3 times as long as they did five or 10 years ago, when they just had carboplatin available. So we don't have a lot of data in the cisplatin eligible population. And I think, I don't think anyone really knows how it's going to fare in the phase 3 trial. Will EV Pembro look better than cisplatin and gemcitabine and avelumab? Will it look the same? May it be a little worse? So I think the regimen's now approved in the cisplatin ineligible population. I think if there were a cisplatin shortage, I might jump to using EV Pembro. I think I'm a little uncomfortable with saying that providers should just be giving EV Pembro to the cisplatin eligible patients, just because there's really not a huge amount of data. I think if there was some real contraindication to giving cisplatin, then yes, for sure. Will one be better? I really don't know. It's probably not totally wrong. Like, I'm sure patients will do well who are cisplatin eligible who get EV Pembro if that happens. But if we have cisplatin available, if the shortage isn't that dire, then the standard recommendation, level 1 NCCN, recommendation is to give cisplatin, gemcitabine, and avelumab maintenance if they have stable disease after the chemo. So that's where I'd stay, at least for the time being.
Yeah, Petros, I'm thinking more. I'm not thinking about even recommending it. I'm thinking about more. This happens in oncology, particularly you have a knowledgeable patient. You might have a medical oncologist as a patient who says, look, I know the data and I'd rather start with EV Pembro, but it also leads into the question of what you would see in a randomized study, first in terms of quality of life during first-line therapy, patient-reported outcomes, chemo versus EV Pembro and Nivolumab, and also survival. When you then you got to factor in second line and beyond. Any thoughts about what you would see quality of life during first line therapy and what you would see survival wise in a study like that, Petros?
Great question, Neil. I think overall, I just want to clarify one more time what Terry mentioned and relevant to your question. I think we do not have data yet with EV Pembro and cisplatin eligible patients. So I think we should stick with what we know. There is a small proportion of patients, about 15%, that may have long-term benefit with cisplatin-based chemotherapy, especially nivolumab maintenance. And we have to see whether that's the case also with Pembro EV. It's likely the case. The local disease, lymph node positive scenarios, not the distant metastasis, but we have to see more data. So I agree with Terry's response. I would consider EV Pembro in cisplatin eligible patients only in 3 scenarios. If you really have a cisplatin shortage, if you have a patient who refuses chemotherapy, regardless of what you say, and despite our recommendation and the detailed discussion, in rare scenarios when you may have a cisplatin allergy or something in the context of the shortage, which is very rare, and we don't see that. But back to your great question, Neil, regarding quality of life. I think it's a great point, and I'm glad you raised this, because I am a proponent of having PROs and quality of life, patient-reported outcomes data as an a priori testable hypothesis with a formal statistical plan being tested in large randomized phase 3 trials like EV302, for example. We have to see what the trial shows. When we think about PROs and quality of life, Neil, in my mind, there's 2 things. It's a, let's say, combination of symptomatic improvement. If you get a great response, and Pembro EV there may have an advantage because you may get rapid response, palliative benefit, symptomatic improvement with Pembro EV, higher chance compared to platinum gemcitabine. At the same time, toxicity is not negligible, and we'll see data by Terry in a moment that about 2/3 of the patients on Pembro EV may have treatment-related grade 3 or higher adverse events that may also impact quality of life. So I think we have to see the data, and we may see some categories like cancer-related symptoms and pain and performance status that may improve early on with Pembro EV, and we may see some issues like neuropathy, things like skin toxicity that may impact the other categories of the PRO. So excellent point, and looking forward to the EV302 data.
Actually, that's a great point you made, though, about the response to the tumor. I'm not sure everybody's aware that the response rate looks like it's higher with EV Pembro than chemo. Is that correct, Terry? And also, what are your thoughts? It's one thing that, sometimes patient-reported outcomes, I see it, I understand it, looks great, pain, whatever. Sometimes I can't figure it out at all. And then I just turn to you all and I say, tell me, what do you see? What's your experience? Are people more comfortable, putting aside the issue of responding to the tumor, which I think is a great point. Yeah. So, Terry, any comments about this issue of greater response rate and also quality of life?
Yeah, definitely. The response rate in the EV103 trial, as I mentioned, in the 2 different cohorts was 65 and 73%, which is pretty high for urothelial cancer. In fact, older studies of carboplatin-based regimens had only about a 36% response rate. So it's almost a doubling of the response rate. To the PRO question, we actually had PROs that we presented at ASCO, a PRO poster, and we have a manuscript that's being submitted, I think, this week, which looked at the outcomes. These were tracked, prospectively in the patients getting EV and Pembro together. And I think the big take-home point was that you saw that at the end of the first cycle, a lot of symptoms actually got worse. Patients were more fatigued. They were not feeling sort of as robust, things like that. And that's the effect of the chemo, the EV itself. But then by cycle 2, they started getting better. And then if you look at the overall shape of the curve, it was sort of a dip and then a rise. And by the end of, 6 cycles or 8 cycles or beyond, patients were feeling much better than they were at diagnosis, or for the most part, feeling better. And, you have to sort of dig into the data. But so I think that there is something to be said for having a good anti-cancer response, getting the symptoms under control. And, in 302, it'll be helpful to look at PROs there as well and see for people who are getting platinum versus EV, is there a big difference here? I'm hoping there is, but we'll have to see.
I'm just going to bring up another point. Again, we'll get to it later, assuming we can get beyond this. I'm getting, carried away here, but when you think about the kind of algorithms we've seen, Petros, of, chemotherapy, avelumab maintenance, or, IO, initially, for example. I'm just kind of curious, often people think about, using enfortumab as the next line of therapy, but what about the patient who's not had an IO? Would you use an IO, or would you want to bring in EV earlier so you get the combination? Any thoughts about when or if you ever do that?
Neil, great question. We published a couple of manuscripts recently. We have a database looking at patients who got checkpoint inhibitor for metastatic urothelial cancer. And we have about 26 institutions mainly from US, a few from Europe. And we try to answer practical questions using this database. Obviously, these are retrospective data with sort of caveats and selection bias, confounding biases, limitations. But what we saw in the first paper, we saw that patients who had upfront early primary progression to platinum-based chemotherapy, like short time to progression on platinum, usually they do not do well with single-agent checkpoint inhibitor second line. So they are not getting salvaged by pembro second line if they progress early on platinums. So this may be the patients I would probably prioritize either enfortumab or erdafitinib. And we can talk about which of the two or sacituzumab down the road. We'll talk about the sequence. But the other patients are those with visceral metastasis, like liver mets, lung mets, even bone mets. Those patients do not do well with checkpoint inhibitor alone, especially after progression on platinum. So I have actually changed my practice, Neil, over the time, and I tend to use it in enfortumab or erdafitinib in select patients based on the biomarker or a clinical trial, of course, in patients with progression of platinum. So I'm actually, in those patients I just discussed, visceral metastasis, early progression of platinum, I'm using checkpoint inhibition later on, and I prioritize enfortumab or sacituzumab or erdafitinib before checkpoint inhibitor in those patients. The big question is, do you use EV pembro combination in patients with upfront platinum refractory disease who never get maintenance avelumab? And I think it's a reasonable approach. The data we have seen from EV-103 that Terry will show, it's all in the frontline setting. Interestingly enough, the FDA gave accelerated approval of pembro EV in cisplatin-ineligible patients, but did not specify the line of therapy. So if I have a patient with really explosive disease with liver mets in the front of platinum-based chemo, and I'm really worried about I have one shot on goal, in that patient I may consider extrapolating from the EV-103 data and potentially giving EV pembro second line in those platinum refractory patients.
So as you can see, we're really oriented, as opposed to your two presentations that just go through voluminous data, where I'm oriented tonight about what you do in practice. Here's where we're going to head over the next few minutes, particularly to go through the survey. Just to remind you, too, that our primary target audience is a general medical oncologist in a community-based setting, same people taking care of CLL, myeloma, you name it. I was just flashing on I was doing a session with a general medical oncologist. I do this where they present all these different cases and then we plug them into various series. And we were talking about bladder cancer. And I said, you have any questions you'd like to hear faculty discuss? She goes, well, yeah, I'd like to hear about enfortumab vedotin, what the response rate is, tolerability, et cetera. I say, okay, anything else? Well, I'd like to hear about sacituzumab in bladder cancer. I've used it in breast, but I've never used it in my bladder. Curious about that. Anything else? Well, what about erdafitinib? What kind of, she asked me about that. And then I just thought about it for a second. I said, have you used any of those drugs? No. So this happens all the time. The general medical oncologists are using a drug for the first time. They're not going to use it again for a year, but they got to know what to do. And that's why we're focused on what you're doing in your practice and what really happens. I don't know if you want to comment on this, Terry. This is a slide you showed at the beginning of your talk. But, so many slides. We saw the same thing last night with endometrial cancer. So many slides about nothing happening for 20 years. And then all of a sudden, last night we were talking about explosion. Right.
Yeah.
So, last night we were talking about, incidentally, finally 2 phase 3 trials, both positive, IO plus chemo, first-line therapy of endometrial. Just came out 3 weeks ago.
Fantastic.
And again, everything stacked to the right in endometrial as well, antibody drug conjugates, et cetera. So, Terry, can you you go through this in detail, but maybe just sort of highlight your vision of sort of the algorithm you have. So many of these people are older and platinum ineligible. When you first hear that you're going to see a patient with metastatic urothelial bladder cancer, what are some things you're thinking about?
Yeah, I mean, the first thing I think about if we're talking about systemic therapy is, are they fit to get platinum? Are they fit to get any platinum or cisplatin? And that's where the first, choice here. Unfortunately, bladder cancer is a disease of the elderly, and sometimes we have very frail elderly folks. They're not eligible for any chemo. And so you can see on the right side of the screen there, pembrolizumab's technically approved if you don't think you can give them any chemo. Or putting them in clinical trial or best supportive care. If they're platinum eligible, meaning cis or carbo, then we in bladder cancer have prospective guidelines that tell us whether someone should get cisplatin. And broadly, it's, do they have bad neuropathy? Do they have bad hearing loss? Do they have bad renal function? And actually, that's on the slide right here at the bottom, or heart failure or poor performance status. If they have, those metrics of, then they should not be getting cisplatin because outcomes are poor. So as of today in 2023, if someone's eligible for cisplatin, we should give it. And actually, if you go back to the last slide, when we take someone in that blue box who's cisplatin ineligible, we just had this EV Pembro data, which we've been talking about, and you can see it was just approved in April. And this is a choice now. They've not been compared head to head. At least the data has not been published. That's the subject of the phase 3 trial, the EV302 study that we're all waiting for. So you can either give carboplatin, gemcitabine, and avelumab maintenance for patients who have stable disease or better, or give EV Pembro. And I don't think there's a right answer. I do like the idea of giving the immunotherapy on day one. You get the immunotherapy in and you capture patients. We know in urothelial cancer that about a quarter of patients never get frontline therapy. They're just too sick. They have access issues. They have barriers. They never get treated for metastatic disease. And after the first line, about 50% of people never get to the second line. And so that slide we had even before where we saw like 9 new drugs, I think the movement in the field now is to collapse these regimens together to do combination therapy. And that's really what we're seeing with EV Pembro. And so that's sort of how I'm approaching the front line of bladder cancer, at least today.
So any comments? I was just thinking, you need to change that algorithm to carbo not available, cis and carbo not available, break the whole thing out. Can you imagine the algorithm there? But really, we kind of need it, hopefully, not too long. Any comments on the issue of cis ineligibility and platinum ineligibility? I know that's a little bit less defined. Petros, how do you approach that issue? And particularly, who do you call platinum ineligible, both cis and carbo?
Great question, Neil. So I agree that Terry mentioned cisplatin eligibility have been mainly based on the GALSI criteria. There's some variability based on the kidney function, the GFR, renal function. We may have different cutoffs. For example, creatinine clearance of 50 cc per minute or higher may be adequate for me, but others may want to go up to 60. Some other people may go lower to 40 or higher. So there's some variability in what threshold of GFR you use for cisplatin across different providers. With hydration, maybe single dose cisplatin. The other question is the hearing loss, which may be a little bit of discussion with the patient. Is it a curative intent versus palliative intent of therapy? How does hearing factor in? Does the patient have really worry about it or not? So all these factors may be some variations on the GALSI criteria. Now, the platinum, which is cisplatin and carboplatin, together, fitness eligibility criteria, it's a little bit different. And Dr. Shilpa Gupta from Cleveland Clinic led the consensus-based survey. 60 of us go together and we try to answer a survey similar to the surveys that you do so well, Neil. And we try to come up with some consensus of who are the patients who we are not feeling comfortable giving even carboplatin. So cis and carbo, so-called platinum ineligible patients. And what we came up with was a creatinine clearance below 30 ml per minute. Even gemcitabine can be tricky with low GFR. Patients with ECOG PS of 3, patients with ECOG PS of 2 plus, GFR below 30, patients with peripheral neuropathy grade 2 or higher because of the challenge with even neuropathy with carboplatin in some patients, and patients with symptomatic heart failure. And those factors, if you add them together, it's probably between 10, maybe 15% of patients in my practice meet those criteria that are not platinum fit and may end up getting pembrolizumab alone in my practice. If I have a clinical trial, that would be a great option. It's a hard population to accrue. The big question, of course, is would we envision any patient who meet this criteria that someone would give Pembro EV, maybe dose adjusted, versus Pembro alone? And I think that's an unanswered question and depends on the degree of comfort of the providers and the patient's preference.
So if you want to hear something kind of humorous, the oncologist that I was just talking about is in the chat room tonight, and she just sent me a smiley face. So thanks a lot. Anyhow, all right, let's talk a little bit about EV, and particularly EV Pembro. Anything you want to say, Terry, when you said, chemo side effects, I guess it's a reminder, I think of antibody drug conjugates, as targeted therapy, but more and more, I think, particularly with TDXD, for an example, and HER2 positive, we see a lot of chemo side effects. So yeah. I guess it is important to remember that we are delivering chemotherapy. But let's talk a little bit about the EV Pembro data. Again, your talk goes through all the different studies. Maybe you could just summarize where we are and where you think we're going to be in the next year or two, Terry, with this combination.
Sure. Just to your point about EV as a chemo versus targeted therapy, I call it chemotherapy. I'm very upfront about that because I think it's better that patients are expecting side effects, even though it's exciting and it's new and maybe it's better. We'll see. I think it's just setting the table and calling it chemotherapy is helpful in many respects. So the EV-103 study, was designed because there was some evidence that when you give EV, at least to cells in a culture, there's actually immunogenic cell death. Immune cells infiltrate the tumor and, then sort of EV somehow drives that. And so that was the rationale for combining it with pembrolizumab. And so EV-103, the study you have posted here, was a multi-arm study where there were multiple different cohorts. And the one that's really been most examined is EV and Pembro together. So there was this cohort A that our colleague Dr. Gupta just presented at ASCO as well, and has now been published. And this was the dose finding, initial cohort. What we saw was when you give these two drugs together, you get a 73% response rate. And I think that really kind of knocked our socks off because no one was expecting response rates that high. We know with EV alone, it's about 45% response rate. So when you add it with the Pembro, it's certainly additive in terms of the benefit. And I think one of the major questions is it synergistic? Is it like 1 + 1 = 3 here? We're getting more benefit by giving them concurrently than we would if we just gave them in sequence. The other important thing here is that we saw 15% complete response rate. We saw less than 10% of patients had primary resistance or progressive disease there, or just about 10%. And then in the terms of the longer term effects, we saw the median OS of over 2 years. And I mentioned this earlier, there was a phase 3 trial of carboplatin and gemcitabine in this basically the same population 10 years ago. Median OS was 9 months. So we're seeing a tripling, at least in a small cohort here, of the median OS with this regimen. And it just shows you how powerful, some of these new therapies really are. And because of that, cohort A, a larger cohort was designed and we carried out this study. We did a randomized cohort where we looked at EV plus Pembro and compared it to EV alone in the frontline setting in this same patient population. The EV alone was to get a sense of what the toxicity profile of EV by itself is and what this combo toxicity profile is. But otherwise, the regimen was almost identical. We put about 140 patients between the two arms. And as you can see from this waterfall plot, almost every patient had some degree of tumor shrinkage on the initial scans. The median time to response is short. It's like on the order of 2 months. So basically at the first imaging, you generally see a response, and that's really helpful. And then when we looked at the longer term outcomes in terms of survival, they basically mirrored cohort A. So we're actually technically the median survival has not been met after 18 months of follow up. But, based on what we're seeing, I think it's going to track very closely with what we've seen already with cohort A. So overall, it was really encouraging that the numbers kind of held up in cohort K of this study. And that's really what drove the FDA approval, was seeing, real activity in a decent number of patients.
So Petros, I'd like you to take a look at a couple of the questions we asked the faculty. I was going to say there was a consensus about first-line therapy. Then I just noticed that Betsy Plimick says Pembro rather than avelumab, but that's kind of interesting. But I call this generally a consensus, at least in terms of the strategy. Also, that PD-1 is not a factor in making the decision. We also asked about an 80-year-old patient who's not a candidate for cisplatin. But it's interesting. Most people say Pembro EV, but a couple people say in an 80-year-old, they would still try carbo gem followed by avelumab. Any thoughts about first-line therapy, Betsy's preference for Pembro, and particularly the 80-year-old Petros?
Neil, great scenarios. So I think overall there was a consensus, as you mentioned, for cisplatin-eligible patients. People would use Gemcis, and those with response or stable disease switch maintenance avelumab based on the Javelin Bladder 100 trial with prolonged overall survival and progression-free survival. In terms of the pembrolizumab as a switch maintenance immunotherapy, there was a phase 2 trial by the Hoosier Cancer Research Network published by Dr. Galsky and colleagues, and that actually showed the PFS benefit with pembro. It was a smaller trial, 107 patients, significant PFS, but there was no overall survival benefit. So I personally think it's important to stick with the level 1 evidence and go with this trial that showed the OS benefit that was a Javelin Bladder 100. Therefore, I have been using avelumab, and it seems like for other colleagues do the same thing. Obviously, avelumab is given every 2 weeks and is given until progression or an acceptable toxicity. So it's a significant treatment burden for the patient. And I think Dr. Plimak has a great point there that this treatment burden, is relevant. We have no good data about longer intervals for avelumab doses, so we're kind of stuck in that 2-week interval. Could we potentially do it less frequently? You could envision extrapolating in patients who may need to go for a trip, have some social engagement. But technically, we try to use avelumab, and then pembro can be used again in very rare scenarios. Someone has a very rare, significant infusion reaction, for example, with avelumab. Usually those are mild to moderate. You could potentially switch to pembro. But I understand your point is mainly the treatment frequency, especially if pembro can be given every 3 or 6 weeks. Having said that, I think majority of us give avelumab in that setting. In terms of the cisplatin-eligible patient, an 80-year-old gentleman, with the option of carbogem followed by avelumab or pembro EV, as Terry mentioned before, I think either option is very reasonable. We have level 1 evidence with carbogem followed by avelumab. People are familiar with toxicity profile. They know how to manage those patients, kind of predictable to a degree. So it's manageable. Having said that, I think especially patients who need a response right away, visceral metastases, explosive disease, symptomatic disease, carboplatin shortage, all of those factors may make you choose pembro EV. And because the majority of patients had visceral metastases, that's why I think at least 4 out of 6 choose pembro EV in that setting. But I can envision patients who may choose either or, and it needs an informed and shared decision making with the patient.
So before we go on to second-line therapy, one other question / thought to you, Terry. One of the things we see, and, it's pretty clear in lung cancer, but a lot of the other solid tumors, maybe not quite so, there's not as many patients, it's hard to say. But clearly you do see some people who get IO alone and, 2 years later, they're free of disease. You're trying to decide whether to stop it or not. You presented an incredible case during your presentation, Terry. I think a 76-year-old woman with Parkinson's in terrible shapes, this huge tumor. She's in CR, I think 3 years later. And I think there's this feeling that if there's going to be a home run, it's going to be from the IO, or at least the likelihood is. And like last night, we were talking about, should you use the IO with chemo first line or wait? Because they've been using it second line. And one of the points that Brad Monk brought up is, quote, you want to get your best drug in first. But I think what he was trying to say is, if you're going to see a home run, it's going to be with an IO. And therefore he wanted, even though maybe in the long run, maybe this trial wouldn't show a survival benefit, but kind of looking for the home run. Any thoughts? Is that a reality in urothelial bladder cancer, Terry?
Yeah, I mean, there are patients who respond to single agent checkpoint inhibitor and have dramatic responses. I have a number of them, and I follow up with them 5, 6, 7 years later. That one with Parkinson's brought her, like 3-month-old granddaughter into the clinic 3 years after diagnosis. I thought she was going to die within months when I first met her. So the question today is there still a role for single agent IO? I think the challenge, certainly in bladder cancers, we have no good biomarker to tell us who that woman is. When the next patient walks in the door, is that patient going to respond to a single agent checkpoint inhibitor? There's certainly less toxicity giving IO monotherapy compared to EV pembro. As I mentioned earlier, there's this huge step off with every line of therapy in bladder cancer. So if we put barriers in front of patients and say, no, you have to start with platinum, and then only then can you get a checkpoint inhibitor, we end up losing patients who never, for whatever reason, never make it. So I think there's a lot of rationale to be using sort of, as just like we were saying with your colleague or guest last night, the best foot forward. And, I'm trying to think, if I saw that same woman now who, today, and we had EV Pembro, would I have given her just checkpoint monotherapy? I might not have. She had really ugly looking cancer. I probably would have given her both. And then I would be out here being like, wow, EV Pembro works so well. So, unless we do our head-to-head study, we're never going to know for sure. I don't think we're ever going to do a head-to-head study of IO mono versus anything else in bladder cancer, because we have a good sense of how IO monotherapy works. I wish we had better biomarkers. I wish we had something that could tell us very clearly who's going to respond and who doesn't. PD-L1 works in lung cancer. It works in head and neck cancers. It really doesn't seem to work well in bladder cancer. There have been multiple phase 3 trials that just don't or show that the PD-L1 biomarker is not enough to discriminate between who's going to respond and who isn't.
So when I was talking about getting the INO early, I wasn't necessarily talking about monotherapy. I was getting back to my original question earlier about EV Pembro, that you're getting the Pembro right away, whereas when you go chemo, avelumab, I don't even know. I think a fair amount of people don't even get to avelumab because they're progressing.
Right,
so
exactly.
Do they get it second line, and what kind of shape are they in at that point?
Exactly. So that's why I think there's a rationale, to be giving the IO earlier. And as I mentioned earlier too, there may be some synergy, right? 1 + 1 might equal 3 by giving them together. We don't know that for sure, but that's clearly of interest. So I like the idea of, you have the patient in front of you, you're about to give them treatment, give them the treatment, get the IO in. Obviously we need the phase 3 data to be sure that that's the right way to go. But that's why, my response on that last slide was to give EV Pembro over carbo, based therapy.
So, Petros, let's talk a little bit about the other antibody drug conjugate that's approved in the bladder cancer. I'm always bragging about bladder cancer. You're the only ones with 2 antibody drug, I think. Well, HER2 positive breast cancer, that doesn't count. But anyhow, and speaking of breast cancer, of course, most docs have experience with sacituzumab in breast cancer. Very successful drug. I mean, it works in breast cancer. You have to deal with tolerability issues, but that seems okay. Can you chat a little bit about what we know about what Joyce O'Shaughnessy calls SASI in bladder cancer, Petros?
Thanks, Neil. I remember early days when we were starting about developing this drug back about 5 years ago. And I think from the beginning there was enthusiasm about the mechanism of action. As you saw in this slide, this antibody drug conjugate is different than enfortumab in many ways. Number one, different target. This is TROP2 versus Nectin-4. It's a different linker that can be hydrolyzed, and this can release the payload, even the tissue microenvironment. And people are wondering whether this may or not have to do with the efficacy of the drug, bystander effect. Hard to tell. The payload is a SN38 and very active metabolite of irinotecan, so a topoisomerase 1 inhibitor. This drug showed very interesting activity early on in a phase 1 trial that Dr. Tagawa, Dr. Faltas led, and the response rate was 31% in patients with prior therapies. So definitely a very impressive response rate comparing favorable with historical controls. That led to a very relevant phase 2 trial called the Trophy U01 that had multiple cohorts. Cohort 1, 2, and 3 have been presented. Cohort 4, 5, and 6 are ongoing in the frontline setting. And cohort 1, single agent sacituzumab govitecan, after prior therapies, after chemotherapy, after checkpoint inhibition. This trial allowed any number, unlimited number of prior therapies, multiple pretreated patients, and showed a response rate of 28% with SATSI alone. In this heavily pretreated population, the median, as you see, duration of response was about 5 to 6 months in that cohort 1, median PFS about 5 months, and median OS approaching 11 months. Obviously, single-arm phase 2 trial. The FDA gave accelerated approval to this drug based on the phase 2 data with a contingency at the phase 3 trial, which, by the way, it's called TROPICS 04, taxane or vinflunin in the control group versus SATSI, which has finished accrual, results are pending, will be done, and that trial is ongoing now. At the same time, we have very quickly to mention some data in the second line space, single therapy, monotherapy of sacituzumab in patients who had progression on a checkpoint inhibitor frontline. They got pembro or atezolizumab frontline. They had progression, cisplatin ineligible patients. They got SATSI second line, 32% response rate. So promising. the drug has no FDA approval in this second-line space, post-checkpoint inhibitor, but there's activity about a third of the patients. And what you saw in this slide here is the cohort 3 that I had the chance to present at ASCO GU 2022 and 2023. This is Pembro plus SACI combination. This is platinum refractory population. They never got available maintenance, and they have platinum refractory disease. We discussed earlier that these patients do not do well with IO alone. The combination looks pretty active, 41% response rate with a combination with longer follow-up. It met the primary endpoint, and right now we're discussing about a phase 3 trial with Pembro plus SACI in previously treated disease. So more to come. Toxicity profile, of course, is a little bit different. Neutropenia, growth factor support is very important as primary prophylaxis. Diarrhea can happen with many patients. Fatigue, GI side effects.
One of the things you mentioned in your talk was the issue of UGT1A assays, or any situations where you actually do that in patients getting sacituzumab. I don't remember hearing people bring that up in breast, but I think it's a very good point.
It's a great question, Neil. So we saw some data at ASCO. Johan Loriot saw the data just a month ago, and we will look at the treatment-related adverse events in patients with a wild status of the UGT1A1 or heterozygous or homozygous status for the allele that may impact the metabolism of SN38, the metabolite of irinotecan. And if you have the homozygous allele that is involved in less metabolism, you may have more drug floating around, less breakdown of the drug, and in theory, more toxicity. We saw some numerical differences. Those patients with the homozygous allele that is impacting the function of UGT1, they have higher risk of adjustment of the dose of SACI, dose reductions or dose halts or discontinuations. However, because of the frequency of the homozygous allele and the totality of the data in urothelial cancer, we do not check UGT1A1. So for the practicing oncologists out there, there is no practical need to test for UGT1A1. However, if you see an out of proportion toxicity, significant neutropenia despite growth factor or dose adjustments or significant diarrhea, I think it's reasonable to send that because it might potentially give you some heads up about toxicity of the drug. As I mentioned before, in my opinion, it's very important to use growth factor GCSF as a primary prophylaxis up front from the beginning, from the first cycle of for those patients with sacituzumab.
So, Terry, I'd like your thoughts on sacituzumab. I showed the graphic that shows investigators generally using enfortumab first. I think that people think there's more data. I'd be curious to know what you think we're going to be doing in the future. Also, quality of life sacituzumab versus enfortumab. We asked here about the faculty's experience with dose reduction with sacituzumab, and you can see it's substantial, but kind of like all over the place. What's your experience with sacituzumab, and do you think ultimately it's going to be sort of lined up with enfortumab, or is enfortumab always going to be before it?
Sure. Yeah. I mean, it's interesting. They were developed, at least at the beginning, kind of at the same time. There was a development hold on sacituzumab for about a year, and that allowed EV to sort of generate more data. And I think, EV got an approval before SACI did. And so that sort of put EV ahead of sacituzumab in most of the treatment paradigms. When you look at the monotherapy response rate, EV looks a little better, and, it's cross-trial comparison. There's a lot of issues with doing that, but EV was about 45%, sacituzumab's more around 30%. So, is one drug better than the other? We'll probably never see a head-to-head study of these two. In fact, there's a study at Dana-Farber that's combining the two in the same patient. So maybe they'll just be friends and we'll end up giving both. I mean, we'll have to see how that study looks. But so I have a feeling that what we're seeing is we have sort of three pillars now, or maybe four. We have EV, we have Pembro, we have Platinum, and now we have sacituzumab. And I think, EV may bubble up to the top if 302 is positive, and people who progress despite EV Pembro then might be good candidates for SACI or for carboplatin or, potentially cisplatin-based therapies in the second line. I think we need to see more data. The data, even though SACI's been around for a long time, approved in breast cancer, New England Journal paper, we actually have very limited data in bladder. The initial studies that Dr. Grivas was just talking about are, double digits, one or two of them are maybe a little bigger, but we really need to see the TROPiCS-04 study and really see how it performs in the third line setting. And I think that'll inform us as to like really where SASE fits. I give it after progression of EV Pembro and generally after platinum. I actually have a patient who's responding to it. I'm seeing him tomorrow and he's thrilled. So it really does have a role. He actually didn't respond to EV. And so I think trying to understand biomarkers, who's going to respond, who's not. I mean, there's so many questions there.
So yeah, and actually interesting question in the chat room from Andrew Petros. He says, I do so much chemoradiation for elderly patients who decline surgery for muscle invasive disease. These patients are clearly high risk for progression. Are there trials evaluating the addition of IO or ADCs or after chemo RT?
That's a great question. Thanks to Andrew for asking. So there have been some phase 2 trials data, very promising, evaluating the role of checkpoint inhibitor. For example, pembrolizumab, we saw data ASCO 2023 a month ago by NYU that showed that gemcitabine plus pembrolizumab plus radiation has a very promising disease control rate for muscle invasive localized disease. However, for now, we're waiting for phase 3 trial data before we use checkpoint inhibitor for chemoradiation in bladder preservation. The one trial that comes to mind is the SWOG NRG 1806 chemo RT plus minus atezo. There's also the Keynote 992 chemo RT plus minus pembro. Both trials of chemo RT plus minus checkpoint inhibitor after maximum TURBT. Until those trials read out, the phase 3 trials, I'm not using checkpoint inhibitor with chemoradiation after TURBT. I'm waiting for the phase 3 trials. There are some other trials that are looking at ADCs, and I think these are promising, but very early in the development. So for now, the role of checkpoint inhibitor or ADCs remains experimental for bladder preservation setting.
So Hassan in the chat room wants to hear about erdafitinib. We're about to get into that. Here are a couple more questions from the survey related to sacituzumab. Everybody except Betsy uses preemptive growth factors. She's a little bit of a rebel, I guess. Also, what do you do in a situation where a patient gets neutropenic without fever? Most people would hold the SG and restart at a reduced dose. We also ask, do you use preemptive medication? Terry, you were talking about viewing this as chemotherapy. Same thing with TDXD. You know, they're using preemptive GI meds as well. Many are for diarrhea as well. Terry, can you provide a little bit of an overview of erdafitinib, FGFR mutations, which seem like they're not as common as they were hoped to be, but still a lot of people. I mean, we have all kinds of treatments for very, very rare disease. There are plenty of people with FGFR metastatic bladder cancer. How do you pick this up? What kind of assay do you use, and what's your experience with erdafitinib, Terry?
Sure. Yeah. So it's exciting that we actually have a targeted therapy that's based on a mutation or molecular finding in the tumor, and that's FGFR3. You know, it's a little more common in upper tract tumors compared to lower tract tumors, but globally it's about 20% of cancers, bladder cancers, that have these mutations, and they really drive the progression of the disease. It's also, by the way, seen in cholangiocarcinoma, where you can see FGFR2 mutations and their FGFR inhibitors approved there as well. So erdafitinib is a pan-FGFR inhibitor. It's one of the first out of the gate. And that was just evaluated. Actually, the data was presented in this phase 3 trial, the Thor study. And you can see the data here, which showed that when you compare it to chemo, there was about an overall survival of about a year. The response rate was about 46%. So that's pretty good. You know, that's what we see with EV monotherapy. I think what I didn't show on this slide is the toxicity, the side effects. And I think the challenge is FGFR is important in healthy functioning of your body, specifically in phosphate metabolism. So patients have to go on a low phosphate diet when they take erdafitinib, and that can be challenging. There's also hand-foot syndrome. There can be oral ulcers. There can be a lot of other problems, and actually retinopathy, which can be serious. So, you know, when I give this drug, when I find a patient who has this, I tell them I think of it very much like TKIs in kidney cancer. You know, it's oral therapy. I kind of call it oral chemotherapy for the same reasons I call, ADCs chemotherapy, because I really want the patients to understand that this isn't necessarily a walk in the park. And so if I have a patient, I think it's great because it offers another line of treatment. I think some unanswered questions, is there synergy with PD-1? There was actually a study presented looking at that, and it seemed modest, like maybe there's a modest increase in responses when you give it with a PD-1. But, it wasn't dramatic. And then the other question is, if you have a patient who has an FGFR mutation, should you start with erdafitinib? Should you start with EV? Should you start with platinum? And we have registry data. Actually, my colleague here at UCSF, Vadim Koshkin, and others have led this UNITE registry, which is getting real world evidence from patients who are treated. We saw that EV has about a similar response rate in patients who are FGFR mutated as in patients who aren't. And, so that doesn't say that one drug is better or worse. I think both are options. Erdafitinib has an advantage of being oral, so patients don't have to come in as much, but there is monitoring. You actually have to adjust the dose based on the phosphate levels. So that does take some hand-holding with erdafitinib. And last thing is that there's actually a number of other FGFR inhibitors in development behind erdafitinib that may or may not be approved in bladder in the coming years, hopefully more selective for the FGFR3 and hopefully less toxic.
So yeah, a real challenge to use this agent. When we ask people, how do you sequence these three agents post sort of chemo IO approaches, you can see that there's kind of a difference there. A number of people, including Petros, want to start with erdafitinib before either the antibody drug conjugates. Others will go with the antibody drug conjugates. Also, and this kind of emphasizes your point about the challenge, it looks like a high fraction of patients, based on the experience of the investigators, do require dose reduction. Any sort of pearls about using erdafitinib in terms of, Dr. Grivas, in terms of the tolerability? What are sort of the main issues clinically that you run into?
That's a great point, Neil, because it's a drug that has high activity. It's an active drug. Patients definitely can have benefit. Response rates can be in the order of 40% or so, and a significant proportion of patients have tumor reduction on the scans. At the same time, that activity has to be balanced against the potential side effect profile. So there's a number of logistical points that we need to keep in mind when we prescribe erdafitinib, and we need to think about ophthalmology exams at baseline, and then monthly in the first 4 months, and then every 3 months thereafter, assuming no toxicities that need more frequent ophthalmologic evaluation. And the reason is, as Terry mentioned before, the erdafitinib compound, because of the FGFR targeting, may cause some cornea or retinal toxicity. So a baseline eye exam, a dilated eye exam with cornea retinal evaluation and OCT is necessary to evaluate those patients at baseline, make sure there's no pathology that we need to know about. And about a quarter of the patients may have some side effect from the eye. Usually it's dry eyes, and usually get improved by eye drops, natural tears, sort of speaking. However, it's very important to let the patient know to screen their vision daily. We give them the so-called Amsler grid, AMSLER. It's a grid, vertical and horizontal lines with a black dot in the middle, and they look for, screen themselves for blurry vision. They can put in their fridge every morning somewhere that they can remember to screen for it. The other issue is, of course, the diet, and Terry mentioned that before. In a proportion of patients, hyperphosphatemia can happen because you inhibit the FGFR receptor, so you end up with more reabsorption of phosphorus in the kidney. So at some patients, depending on the phosphorus level, you may end up needing a low phosphorus diet, and depending on the level, if the phosphorus keeps going up despite the diet, you may end up needing phosphate binders with meals to reduce the absorption of the phosphorus in the GI tract. The other thing is very close attention monitoring of the patient. Avoid underreporting of adverse events. Bring them in to examine them because some patients may not report skin toxicities. Hand-foot syndrome can be an issue. Think about TKIs. Nail changes can happen in those patients, stomatitis, mouth sores. So a good physical exam, including all the above, is key, along with a very good education of the patient. The other logistical step, Neil, is about 2 to 3 weeks after you start the treatment. The starting dose is 8 milligrams once a day. This is the starting dose for the indication. You need to, of course, bring the patient in, examine them, ask about any side effects, and check labs because you want to check the phosphorus level. And there is a dose titration. For example, if there is no grade 2 or higher toxicity. If there is no eye toxicity at all and the phosphorus level does not exceed 5.5, based on the package insert and the label, you may up-titrate the dose from 8 milligrams to 9 milligrams, which introduce an extra prescription because the tablet comes 4 milligrams, 3 milligrams, or 5 milligrams. So you have to prescribe a new prescription for the patient. 4 plus 5 equals 9 milligrams. Again, in the absence of significant toxicity, as I mentioned, per package insert. So a close attention needs, as you mentioned, someone who has done it before. If not, close attention per the package insert to make sure we follow the logistical steps.
So a final quick topic. I'm starting to think that HER2 is going to be the new MSI or the new BRAF, because I feel like I'm talking about HER2. We were talking about last night with endometrial. A lot of it's because of TDXD, but then all of a sudden, disitamab vedotin, I know the last name, but new antibody drug conjugate to HER2. Terry, what's this about? I think we have seeing data. Pretty good waterfall plot. What is this agent?
Yeah, so disitamab vedotin, or RC48, it was actually developed in China initially, and it's being developed here now in the U.S. with Seagen. It's basically the same payload, MMAE, that we use for EV. It's a microtubule stabilizer, but conjugated to essentially an anti-HER2 antibody. There have been a number of trials, sort of smaller studies, looking at trastuzumab, looking at TDM1, and looking at TDXD in bladder cancer. And HER2 has always been the stepchild of bladder cancer. It's about 15 or 20% of bladder tumors are high HER2 expressors, but we've not yet really seen a strong signal by blocking HER2. And you could argue that might be due to some trial design issues. Regardless, in this study, this initial one that you're showing, you can see the waterfall plot looks great. Patients are responding, and even patients with, IHC3 or 2+ were responding. So there's early data here. This is being rolled out in a phase 2 and now a phase 3 trial here in the US. I think the toxicity profile from what I've seen is similar to what we see with EV. And the question is, how important is targeting HER2? And I guess we'll have to see.
So yeah, pretty interesting. Pretty good waterfall plot for HER2 1+. So maybe we'll see what we're seeing in breast cancer with his HER2 low.
With the TDXD.
Well, we could go on and on, but we've come to the end of our time, and I think it is just really significant that in an hour it's just impossible to even cover metastatic disease, let alone urothelial bladder cancer. We got all these cases in the chat room we're not going to be able to get to, but we'll get to them eventually. Terry and Petros, thank you so much for working with us today. Audience, thank you for coming here today. For your nurses, let them know about our conference next week on CLL. Be safe, stay well, and have a great night. Thanks so much, Terry. Thanks, Petros.
Thank you, Neil. And
thank you so much, Neil. Thank you.